Okay, good afternoon, everybody. Welcome all of you with us in the 7th Ain Shams University International Clinical Oncology Conference. I'm really glad to be with all of you, but I hope next time would be face-to-face. It's my honor to present Professor Gracier. He is the professor of breast oncology and professor of medicine at Northwestern University at Chicago. He is the current chair of the National Comprehensive Cancer Network, the NCCN Breast Cancer Guideline Panel. He is the consultant of the Oncology Drug Advisory Committee of the FDA. Welcome, Professor Gracier, and okay, welcome with us, and I hope you will be with us in the following conferences. And please, it's glad to hear from you the NCCN guidelines development for breast cancer. Okay, Professor Gracier.
Thank you. I think you can see my slides, but Zoom says that you shut off my video, so you can't see me. So if you want to, I think the host has to let me in. But I'm going to keep going. So thank you very much for the invitation. I very much appreciate it. And what I'm going to talk about are the development of the NCCN guidelines as it relates to breast cancer, with some specific emphasis on global programs. I think that most people listening are familiar with the NCCN. It's an alliance of 30 different institutions in the United States that are focused on patient care research and education. And the ultimate goal is to improve the outcome and care of patients with cancer, not only in the United States, but ultimately around the world. And this is the distribution of the centers that are involved. I'm in Chicago. Dr. Graylow, who's following me, is over here in Washington, and her colleague Ben Anderson has been the co-chair of the committee for many years. So there's a distribution of many centers that you're all familiar with in name, to get a sense of how broad the representation is. With respect to NCCN guideline development, it's a very regimented approach with respect to how we go about looking at development of individual guidelines. All right, I guess I can start my video. There I am. Okay, thank you. If you look at the guideline development, you can see that we do a broad institutional review. We're very aware of the newest things that are being presented at congresses around the world, as well as the most recent literature. The panel, at least with the breast cancer panel, convenes face-to-face once a year, but not uncommonly, there are many virtual meetings or telephone conferences to discuss new developments. We try to update the guidelines, and then they're reviewed. Anything that changes in the guidelines has to be voted on by the members, and then those guidelines are updated periodically, as I already said. Currently, there are 73 different NCCN guidelines, and as you know, because I'm sure you've looked at least some of them at one point or another, these are often massive individual documents, and they currently cover about 97% of all the cancers seen in the United States. So for the most part, we have a way for practicing physicians to be sure they're delivering optimal care based on evidence-based medicine. And I showed you a moment ago the distribution of centers that are involved. This is the current panel of people who serve on the breast cancer panel. Going through the names isn't important, but what I want to draw your attention to is that it's represented by all the different modalities and individuals with expertise caring for patients with breast cancer, be it surgeons, radiation oncologists, medical oncologists, reconstructive surgeries. We have a patient advocate, and we also have primary care physicians who are also involved in the survivorship programs as well. I want to shift gears a little bit to more of a global presence that NCCN has. And if you look at the use of NCCN guidelines, you can see that if you look at the number of different registered users, it's approaching 1.5 million. And probably at least half, if not closing in on half, are from international sites. And you can see on the right Again, just putting it in perspective that it's almost 50-50 in terms of use in the United States or outside the United States. Distribution around the world is represented here. Obviously, there are some very heavy users in India and China, but you can see that the use is distributed all over the world, including Egypt, South America. Obviously, Europe uses them as well as their own guidelines. And you can see the distribution here just in a bar graph fashion, saying how frequently cancer specialists in different parts of the world access these guidelines. And this is really just from January of this year. So this is a very widely used tool that physicians use. And not surprisingly, if you look at the increased use over the last decade and a half, what's most notable, and this is largely reflected because of other parts of the world using phones for so much of their day-to-day activity, mobile applications really account for a growing, significant fraction of how users access this tool. So what I'd like to now focus on for the remainder of the talk is some of the other efforts that we have within the NCCN, and that is to look at resource stratification. And that is, we try to develop evidence-based guidelines that are largely focused on use in the United States, recognizing that around the world, resources are not necessarily identical. And we want to be able to suggest, we don't mandate, of course, but suggest that as resources become more limited in different parts of the world, what would be the optimal ways of applying the NCCN guidelines? So we've developed a framework that takes into account the resources that may be available in different parts of the world. And this effort really now is reflective of being able to offer something for 75% of all the cancers in the world using this framework methodology. And basically what we're doing, and I'll use obviously the breast cancer guidelines as an example, is we try to develop a tool that takes into account different levels of resource availability, those that are referred to as basic, core, or enhanced, with increasing resources available as you go from left to right. And the idea is that incrementally, as resources become more available, the appropriate next things that are available to physicians and their patients would go up in a way that makes strategic sense. And here on this table, you can see that how we define the different levels in this framework. Basic resources are those that we view as the bare minimum that you have to have. Otherwise, you shouldn't be taking care of breast cancer patients, or for that matter, depending on the guideline, any cancer. You have to have certain tools to even try to take care of patients with cancer. Core level of resources are those that include the basic resources, but then additional things become available that may impact on survival and not be cost prohibitive to health ministries or health systems in that particular country. And then finally, as resources become more plentiful, we have a category referred to as enhanced resources. Some of these are out of reach for very low resource settings, but as economies change and availability of different things become more readily available, this is an appropriate level of care to suggest to patients. And we'll go through some examples about how this actually works. I showed you how the guidelines work when we are trying to develop them in the United States. The framework development for resource stratification is somewhat different. We already have the established guideline that we developed for the United States. We then assign members of the panel from each of the modalities to look at the guidelines and try to assign the resources that are appropriate for each level, basic, limited, or enhanced. And then we review this by the framework committee, and they're ultimately, of course, reviewed by international experts from the regions around the world that may be using this. We don't want to presume that we know what's available everywhere or necessarily what's appropriate everywhere. We definitely need the feedback of people who are living in those regions. So let me just give you some examples from the guidelines about how this stratification works. The time will not allow to go through the entire guideline, but I'll just give you a few examples. If you refer to the breast cancer guideline, you would see one color, everything would be in black. But within the resource stratification guidelines, you'll see that, for an example, in the workup page of the guidelines under the basic resource, you'll see certain things remain very black. These are things that you need at a basic level to be able to take care of patients with breast cancer. Certain diagnostic tools like a mammogram, an ability to evaluate hormone receptors, some very fundamental tests that are done, such as a CBC and a chemistry profile, but more exotic things, more things that cost much, much more, MRIs, scans, etc., maybe not appropriate for this level. Now, as you graduate up, this is the core resources. It, again, has many of the same things present, still avoiding the use of very expensive tools like CT scans, MRIs, PET scans, things like that, genetic testing, which may not be available. And then when you get to the enhanced setting, where resources are much more plentiful, then you start to see the tools that may impact on decision-making and ultimately perhaps impact on how you approach an individual patient. So you have much more sophisticated ability to do genetic counseling, perhaps fertility discussions. The systemic evaluation of disease includes scans such as CT scans, perhaps even an MRI. Even things like PET scan, we still feel is out of reach, even within this framework, but most tools are available. Another example, and in this case, this is patients with evidence of metastatic disease, either de novo or recurrent disease. In a very basic framework, we recognize that you're not going to have a lot of tools, but we still think that it's appropriate to understand whether a patient has hormone receptor positive or negative disease, because one of the few therapeutics that may be available in that setting is endocrine therapy. If bone disease happened to be present or you suspected it, we don't have the use of bisphosphonates or things like denosumab in that kind of setting. As you go up in a core level, it's still very much the same, but then as you get to a resource level where you are at the enhanced level, we now start to see that there are more options that are available to patients. Not only do you have endocrine therapy as a single agent, perhaps drugs like tamoxifen, or even in postmenopausal women, aromatase inhibitors, but we start to see the ability to either ablate the ovaries surgically, but also medically. So as you graduate up within the framework of having more resources in the region you live in, it makes sense to gradually increase the things that are available, not only from the standpoint of evaluating patients, but also having certain therapeutics that are available as well. An example where things have certainly grown dramatically in the metastatic disease setting, and Dr. Grayla will talk about this, I'm sure, in some detail in her talk, using this as an example in patients who have HER2 positive disease, something for which we have many, many therapies. But if you're at a basic resource level, none of these things are really available, and you're not even doing HER2 testing. As you increase and have a more enhanced setting, then you're going to have an ability not only to test for whether or not the tumor is HER2 positive, but you're going to have some certain basic tools available, such as trastuzumab and perhaps certain chemotherapies. The most recent drugs that have been approved, and even some that are perhaps a little bit older, like pertuzumab, all of which I'm sure, again, Dr. Grayla will talk about, these are still out of reach, but we start to see the development of certain things becoming available, and that extends the ability to take care of these patients. The guidelines, as you know, don't just cover medical oncology, they cover surgical considerations as radiation, as well as radiation oncology. And if you look at the principles page in the guidelines for radiation oncology, it's completely grayed out under basic resources, because most of these things are not available at the most basic level. Even very simple radiation therapy or older machines may not be available. So we don't even presume that is going to be something that is available in certain regions of the world. But as you increase your resources, then we start to see on the principles page certain considerations that can be undertaken with radiation oncology. In certain parts of the world, there may be only a couple of machines in an entire country, whereas we in the United States or in parts of Europe may have more machines in one city or town than is available in an entire country. So resources make a difference. So you start to see in black certain strategies that are reasonable to be considered at this level of resources. And then in blue, you start to see the emergence of certain things that might be available or considered, depending if there are centers in your country that have that. And of course, the same applies to systemic therapy for earlier stage disease. At the most basic level, in patients who are HER2 negative, there is really not much available with respect to chemotherapy. And we suggest that that isn't a reasonable thing to do if you can't do the basics already. But as you move up the resource chain and get to the core level, certain things are available, CMF, anthracycline-based regimens. And then, of course, as you get into the higher enhanced levels, we not only see those same chemotherapies, you may actually start to see some taxane use, and there is even a suggestion that in some areas you may have post-residual disease use of capecitabine. So how is this being applied in the world? Well, the framework or resource stratification tools are being used very widely, particularly for breast cancer, if you compare it to the other diseases. If you look at the distribution of places around the world that use this, again, India is a big user, China, and Egypt is a very big user of this tool. And again, if you look at the framework downloads, these are, 250,000 users are accessing these tools every year. And it's equally distributed, looking at the basic, core, or enhanced levels, certainly over the last couple of years. There is an effort, of course, to try to harmonize the guidelines, even with very specific countries or regions, to go above the framework, to look at the parent guideline, the breast cancer guideline that we use in the United States, and then make modifications that are appropriate. This was one that was done in 2019 for Spain. So they keep the parent guideline and then just make adjustments that's appropriate for their region or their country. And a lot of the same things that we just talked about apply here. The parent guideline stays the same. Certain things are grayed out to account for unavailability of those things. The process is very much the same. We start out with a group of collaborators very early from the region. So in the case of Spain, Spanish oncologists and surgeons are sitting around the table. In the Middle East, North Africa effort, there were similar collaborators. And most recently, in sub-Saharan Africa, this was also done. And this is the most recent effort to look at harmonized guidelines that was conducted starting in 2017. And this was an effort that not only was breast cancer, but cervical cancer and lymphoma. And it really accounted for about 43% of the different kinds of cancers that occur in sub-Saharan Africa. As this evolved over the last couple of years, we now have 46 published harmonized guidelines representing all the different diseases for sub-Saharan Africa. And this is my last slide, but this really reflects not the NCCN telling other regions what they should do, but rather an effort to, in concert, in collaboration with local experts, look at what's available, what's appropriate for their region and for their population, and come to some joint agreement about what harmonized guidelines should look like, and of course, maintain the basic framework of the NCCN guidelines. So that's my quick overview of a very broad topic. I appreciate your attention and the invitation to participate, and I'll be available at the end for questions. Thank you.
Thank you, Professor Grachir. And now for the questions, as you said, to be postponed at the end. So please, Professor Yusri, my colleague, to present Professor Jolie Gralo.
Good evening. First of all, I would like to thank organizing committee for giving me the opportunity to participate in this great conference and share with dear chairperson in this session, and have the chance to introduce the next speaker, Professor Jolie Grolot. Professor Jolie is a professor of medical oncology and global health at University of Washington School of Medicine, who is going to talking us about updates in the treatment of metastatic breast cancer. Yes, please, Professor Jolie.
I think I'm unmuted now. Is that correct?
Yes.
Yes.
Great.
Please.
Thank you. Thank you. Thank you. And thank you for the invitation to speak at this conference. I, like all of you, am very sorry that we are not all together, but we will be someday. That was a terrific presentation by Dr. Gradishar related to the NCCN and the resource stratification, something near and dear to my heart. Actually, I co-chair the ASCO Resource Stratified Guideline Group with Dr. Sana El-Shakoun from Jordan. And while I'm very sensitive to the needs of various countries and regions of the world needing to have their own guidelines that are cost-effective, resource appropriate, I am today going to talk about some of the latest updates in the treatment of metastatic breast cancer, all of which for the most part are available in the US and approved by the US FDA, but very expensive, new, and many of them may not be available to you yet, but you probably need to know that they're on the horizon even if they're not available. Here are my disclosures. So let's start with estrogen receptor positive breast cancer. We've had the endocrine therapies for decades and decades. In the postmenopausal setting, aromatase inhibitors. Premenopausally, we can suppress ovarian function. We have the SERMs like tamoxifen, teremofen, the SERDs, the selective estrogen receptor degraders like fulvestrant. And what's new in estrogen receptor-driven breast cancer is combinations with a variety of targeted agents that intersect in various pathways with the estrogen receptor signaling. And these targeted agents enhance the efficacy, help reduce resistance to endocrine therapies. So we've got the CDK4/6 inhibitors, such as palbociclib, ribociclib, abemaciclib, the mTOR inhibitor, everolimus, and most recently approved the PI3 kinase inhibitor, alpelisib. I'm just going to give you a quick overview of the trial that led to the US FDA approval of alpelisib, the PI3 kinase inhibitor. The SOLAR-1 trial was published last year in the New England Journal of Medicine, and this was a trial in postmenopausal, metastatic, ER-positive, HER2-negative breast cancer where all patients got fulvestrant and they were randomized to alpelisib or placebo. Now, they took all comers, but they looked for PIK3CA or PI3 kinase mutations in these tumors by doing genomic profiling, next-gen sequencing. The results were that alpelisib improved progression-free survival response, but only in the PIK3CA mutated cancers, the 60% of these patients that, had a PI3 kinase mutation. There are toxicities from alpelisib. It can cause a rash, and hyperglycemia are the most common ones. with some diarrhea and pneumonitis, and it was FDA approved in the US in May of last year. Now, moving on to HER2 positive metastatic breast cancer, we now have 7 US FDA approved drugs with HER2 as a target, with 3 of them approved in the metastatic setting just in the last year. Excuse me. Here's one of them. This is trastuzumab deruxtecan, or TDXD, which is an antibody drug conjugate. We know we've already had TDM1, an antibody drug conjugate, approved in HER2 positive breast cancer. So this is the second one in that category. So it's a humanized anti-HER2 monoclonal antibody with a cleavable linker, and the payload, the drug, is a topo-1 inhibitor called DXD. The phase 2 DESTINY trial enrolled metastatic HER2 positive breast cancer. All patients had prior trastuzumab and TDM1, and a majority had prior pertuzumab. And this was a straight out phase 2. All patients got this antibody drug conjugate. And what you see here is the waterfall plot as was published in the New England Journal this year. And with all those downsloping blue bars, you're seeing that virtually all of the patients had a response of some kind, which is tremendous in a group of patients who have already had quite a few prior HER2 lines of therapy. So there were frequent durable responses. The most common side effects were nausea, fatigue. It does cause alopecia and neutropenia. And there's a rare but serious side effect that we're paying particular attention to, which is interstitial lung disease. We've also seen some evidence, early evidence, that maybe these lower HER2 expressing tumors, the 1+ or the 2+ that are FISH negative, may have some benefit from this drug due to some bystander effect, and those trials are ongoing. The US FDA gave an accelerated approval for trastuzumab deruxtecan in December of 2019 for patients who had had at least 2 prior anti-HER2 regimens in the metastatic HER2 positive setting. Another new HER2 agent is tucatinib, an oral small molecule tyrosine kinase inhibitor that really is quite specific for the HER2 molecule. The HER2 CLIMB study is the definitive phase 3 trial that led to tucatinib's approval. Again, metastatic HER2 positive breast cancer. All patients had had prior trastuzumab, pertuzumab, and TDM1. A unique feature of this trial was that active brain mets were allowed, not required, but allowed. And so the trial was capecitabine, trastuzumab, plus minus tucatinib. The results are shown here. The primary endpoint was progression-free survival. And the blue curve here is the tucatinib-containing arm. The purple curve is the arm that just got capecitabine trastuzumab. And you can see a clear separation in the curves with a strong p-value for an improvement in the primary endpoint, progression-free survival. Overall survival also had a nice separation of curves here as well. The most common side effects here are diarrhea, hand-foot syndrome, fatigue, and nausea. And it was FDA approved in April of this year in metastatic breast cancer patients who had had at least 1 HER2 regimen. But one of the most important things and exciting things about this trial was, as I told you, they allowed patients with a history of brain mets, and not just a history of, but actually active brain mets. And that was almost half of the patients in the trial, 47% of the patients. 60% of the brain met cohort had treated or stable brain mets, but 22% were untreated and 18% had been treated, but now they were progressing. And here's the progression-free survival in that cohort that had brain mets, and you still see a very nice separation of curves for tucatinib, an oral HER2-targeted tyrosine kinase inhibitor that penetrates the blood-brain barrier. At ASCO in 2020, we had an update on this that also showed a 6-month improvement in overall survival in the brain mets cohort for the addition of tucatinib. So an exciting outcome, especially for our HER2 patients who have brain metastases. The third drug approved in the last year in the metastatic HER2 setting was neratinib. Now, neratinib is another oral small molecule inhibitor, but it also targets, in addition to HER2, HER1, which is epidermal growth factor receptor, and HER4. The NALA trial was a trial of capecitabine with neratinib versus capecitabine with lapatinib. These were HER2 positive metastatic patients with at least 2 prior HER2 therapies. And here are the results as shown at ASCO last year from the NALA trial. Progression-free survival was superior in the blue curve here for the group that had capecitabine plus neratinib versus the gray line, which is capecitabine plus lapatinib. And overall survival is showing not statistically significantly here, but some separation of the curves. Now, it was commented in the trial that although they didn't seek active brain mets patients, that there were fewer patients who required an intervention for brain mets in the neratinib arm. So we've had neratinib approved in the US in the extended adjuvant setting since 2017, and it was approved in the metastatic setting in February of 2020 as per the NALA trial. Also, last year, the US FDA granted neratinib orphan drug status for patients with brain mets based on a prior trial called the TBCRC 022 trial. So this drug also appears to cross the blood-brain barrier. Now, what about triple-negative breast cancer? This is a disease that lacks estrogen and progesterone receptor as well as HER2. And for the most part, up till recently, chemotherapy has been the only real therapy that's had activity. But we've got some changes. And now we have a brand new antibody drug conjugate called sacituzumab govitecan that was approved very recently for metastatic triple-negative breast cancer. So this antibody drug conjugate is an antibody against TROP2, which is overexpressed on more than 90% of triple-negative breast cancer, other breast cancer subtypes such as ER positive, as well as other epithelial cancers. The chemo agent here in this antibody drug conjugate is called SN38. It's the active metabolite of irinotecan. This was a straight-out phase 2 trial with 110 patients who had had at least 2 prior lines of chemo. The median was 3. And what they saw in the trial that led to its initial approval was a response rate of 33% in these heavily pretreated patients. The main toxicities of sacituzumab govitecan are neutropenia, anemia, diarrhea, and fatigue. And the US FDA approved sacituzumab govitecan in metastatic breast cancer that was triple negative in May of this year. Now, just last month at ESMO 2020, we saw the presentation of the ASCENT trial, which is a randomized phase 3 trial of sacituzumab govitecan in triple negative breast cancer versus the treatment of physician's choice, which was one of 4 different commonly used chemo agents. Patients in the study had to have had at least 2 prior chemo agents in the metastatic setting. And the ASCENT trial was halted early per unanimous agreement of the Data Safety Monitoring Committee due to compelling evidence of efficacy across multiple endpoints. Here's the data that was presented last month at ESMO. Here's progression-free survival with the sacituzumab arm in this aqua or greenish color. Compared to the treatment of physician's choice, a big difference here. Median progression-free survival, 5.6 versus 1.7 months. And overall response was 35% versus 5%. And look at this big difference in overall survival. Median overall survival here, I apologize, this should say 12.1 months versus 6.7 months, statistically significantly different. We have ongoing studies of sacituzumab govitecan in the neoadjuvant and adjuvant triple negative setting. the ER positive metastatic setting and in combination with other targeted agents and in other cancer types. So another new class of drugs are the PARP inhibitors, and they're involved in DNA repair. PARP inhibitors block PARP, which is an enzyme involved in DNA repair, along with BRCA1 and 2. And the combination of the presence of a BRCA1 mutation and the use of a PARP inhibitor leads to a synthetic lethality, cell death. Olaparib and talazoparib are approved in HER2-negative metastatic breast cancer that has a germline mutation in BRCA1 or 2. And I would suggest that if you have availability of PARP inhibitors, that we should be considering genetic testing, at least for BRCA1 and 2, for most of our metastatic patients. At ASCO 2020, the TBCRC 048 trial was presented. This was a trial looking to see if PARP inhibitors, such as olaparib in this trial, might have benefit when there are germline or somatic mutations in other DNA repair genes, or when there's a somatic mutation in BRCA1 and 2. So this shows BRCA1 and 2, but we have a whole host of other DNA repair genes that were investigated. Now, this was an early presentation with only 54 patients enrolled, and the most of the mutations were somatic mutations in BRCA1 and 2, and either germline or somatic mutations in PALB2, ATM, or CHEK2. And we did see response for single agent olaparib in the somatic BRCA1 and 2 mutations and the germline PALB2 mutations. So this trial will be expanded in those cohorts. So we may have a role for PARP inhibitors beyond just germline BRCA1 and 2. Now, immunotherapy is the last concept I'll discuss, and we've got a lot of excitement about immune checkpoint inhibitors in cancer in general, and kind of stuttering starts in breast cancer. We do have atezolizumab, a PD-L1 inhibitor approved by the US FDA in metastatic triple-negative breast cancer. Pembrolizumab, we've got a positive trial result, not yet approved specifically in metastatic breast cancer. The Impassion 130 trial was the trial that led to the US FDA approval of atezolizumab in the metastatic triple-negative breast cancer setting. This was metastatic breast cancer, triple-negative, first-line, no prior treatment for metastatic disease. Everybody got nab-paclitaxel, the nanoparticle version known as Abraxane, and patients were randomized to atezolizumab or not. All comers were accepted in this trial, but patients were stratified by PD-L1 status. The results showed an improvement in progression-free survival in the PD-L1 positive group, which was 41% of patients. And as a result of that, atezolizumab was approved by the US FDA in metastatic triple-negative breast cancer. Now, just to confuse the issue, just last month at ESMO, we saw a very similar trial, the Impassion 131 phase 3 trial presented, where really the only major difference in the trial was that instead of nab-paclitaxel, paclitaxel was the chemo agent. These were still first-line metastatic, triple-negative patients. And again, central testing was done for PD-L1. I'm showing you the curves straight from ESMO. No difference in progression-free survival and no statistical difference in overall survival, with the red line here actually being the placebo arm, not the atezolizumab arm. Not statistically different, but the blue line, the atezo line, is not showing up on top. So Impassion 131 did not meet its primary endpoint. There's a negative trend in overall survival, and we're scratching our heads at, does the drug combination really matter that much, and what happened here? Is it steroid use, which was given with the paclitaxel, at least in the first several cycles? We'll have to investigate this further. For right now, only nab-paclitaxel should be given with atezolizumab in breast cancer. The Keynote 355 trial is a trial that's given information to us about pembrolizumab in metastatic triple-negative breast cancer. This is not yet an approved indication, but it's sitting in front of the FDA. In this trial, pembrolizumab was given with 3 different choices of chemo, either paclitaxel, nab-paclitaxel, or gem-carbo, and it was compared to placebo plus chemotherapy. And PD-L1 was tested, albeit by a different way of testing PD-L1, and about 40% of patients in this trial were called PD-L1 positive. This was a positive trial. There was a significant improvement in progression-free survival for patients who had a combined positive score for PD-L1 of greater than or equal to 10. When we looked at the forest plot and saw a breakdown, most of the patients got a taxane. We did not see a breakdown between paclitaxel or nab-paclitaxel, however, so we can't tease that out yet with the data we've been presented from the Keynote 355 trial. So in conclusion, metastatic breast cancer, lots of exciting things going on, and I want to make the case that a biopsy, at least a tissue or a liquid biopsy, is more important than ever. If we do a tissue biopsy, we will, of course, repeat the ERP or HER2 staining because it can change from the primary tumor. We might do androgen receptor staining, and if triple negative, PD-L1 staining. And we're also now routinely sending off genomic profiling, either from the blood or the tumor, and we have more and more actionable findings that we can find with next generation sequencing that I haven't gone into great detail here. We've got studies going on, but the most important being the PIK3CA mutation, where we now have an approved therapy. So thank you very much for your attention, and I'm happy to answer questions at the end of this session.
Thanks, Professor Julie, for excellent and informative presentation. And for audience, please keep any questions or discussion to the end of the session. Professor Naveen, you can continue, please.
Okay, thank you, Professor Joly, for this comprehensive presentation. And now it's my honor to introduce my colleague, Professor Dr. Ahmed Slimane. He's Professor of Intervention Radiodiagnosis at our university, Ain Shams University, and he's a member of the MDT committee of the breast committee, which where we share with us and also the rest of my colleagues in the breast unit various critical cases. So I think his presentation would be part of this. He will discuss the role of intervention radiology in breast cancer. Okay, Professor Ahmed.
Good evening, everyone. A great honor to be part of this scientific event. I'm glad to be here to demonstrate our work in our breast IR unit. Just a sec. Over the last 2 decades, there has been a dramatic drop in the number of open biopsy procedures due to widespread of minimally invasive percutaneous procedures performed under local anesthesia with ultrasound or stereotactic guidance. And this emerged in the presence of the MDT and with the era of the neoadjuvant chemotherapy. Talking about clip localization, this is the traditional worldwide used clip, and we innovated a more cheaper clip that can go on with our in our unit, helping more and more patients. The patient is sent to us after the MDT team if the KI is having promising percentages, and committee decided the patient will take neoadjuvant therapy. Our instruments that we use is ultrasound machine, local anesthesia, surgical cholecystectomy clip. This needs a plan and skill. After revising the radiological data available and a second look ultrasound, the lesion is identified, breast sterilized, local anesthesia administered. The clip is placed under ultrasound guidance with a post-placement confirmatory mammography film taken. Here's a lesion of a dense breast. Sonography showed an ill-defined hypoechoic lesion by RADS 5 and the traditional clip being placed within the center of the lesion. Sadly, this patient had also bilateral cancer or bilateral suspicious lesions, with the other breast also showing a large radiodense lesion where it was also clipped. And this is how does the cholecystectomy clip looks like under ultrasound and in mammography. We can see the difference between, that's the one we that's the cholecystectomy clip, and that's the one, the traditional worldwide clip. And this is a small illustrative video showing how do we place it. We put the clip in the tip of the needle, sterilize the skin, and give local anesthesia, and then advance the needle with the clip seen inside its core, and then we deploy it in the center of the lesion, as we can see. Here's the clip being deployed within the center of the lesion. Okay. And this is a case showing an ugly looking mass having a score by RAD 4C, and this is after the clip placed within its center, and again after having complete radiological response, and the clip seen in place while the lesion totally vanished. And here's another case with also an speculated lesion with the clip seen inside and after vanishing of the lesion. And also here we can see how does it look under MRI, and here also the mass that looked like on the right side showing a pattern of enhancement, and it showed type 3 curve on kinematics. And he is after total vanishing with the clip seen inside with no MRI artifact that can abolish the imaging views. And this is our publication, Cost Effectiveness of Ultrasound Guided Surgical Placement of Clip Placement for Breast Cancer Localization Before Neoadjuvant Chemotherapy. Our current experience: established protocol at Ain Shams University. All patients receiving neoadjuvant chemotherapy have a clip placed if showing response. To date, more than 70 breast cancer patients have clip placed and followed up, and most of them operated over the last 2 years. However, as always, the dilemma of multifocal breast cancer: should we put one clip or more? Should we put a single localizing wire or more? What's the optimum surgical technique? Tumor size, breast size ratio? Can we conserve? And intraoperative pathological interpretations. All these are questions that must be answered carefully before taking the decision of whether to put a clip or not, and accordingly the surgical procedure. Here is a case where we can see the left breast having a large retroareolar speculated mass. Can you see anything else? On the right side, there's a small area of focal asymmetric density. Okay, this is how does it look on ultrasound, showing pattern of microcalcifications. MRI showed left side retroareolar region, ugly looking pattern of enhancement goes on with malignancy, retracted nipple, and on the right side also shows similar looking but a smaller one, but there is no other satellites. Also, the patient has left axillary lymph nodes as well as a small right one as well. So the patient was sent, and the curves show type 2 and type 3 curves going on with malignancy upsloping and plateau, and the other one upsloping with downsloping. So the decision was to biopsy the lesion first, and it showed invasive duct carcinoma with focal DCIS and lymphovascular invasion. And we clipped the large lesion on the left side, and we we saw an area of altered echogenicity, which was clipped, and post mammography film showed the clip within the center of the lesion. Our vision is to establish the practice of wire placement, breast conservative surgeries in Ain Shams University hospitals, and to offer post-biopsy clip localization for all patients with breast lesions. Advances in the sensitivity of mammography and the broader population of women screen national programs. More than 50% of all new breast cancer patients in the UK are screen detected. So, wire-guided breast lesion localization. Around 100% of cases of wire-guided breast lesion localization over the last 2 years, and establishing a standard of practice at our hospital after our MDT team decision. Indication: small non-palpable breast lesion, whether benign or malignant, responding cases with complete radiological response over breast localizing clips, suspicious pattern of microcalcification under stereo mammographic stereotype. Preoperative breast lesion localization aims to successful excision of the target lesion as planned with best outcome and least morbidities. How do we do it? It's performed on the day of surgery, under local anesthesia, under ultrasound or mammography guidance. Tip should be within 1 centimeter from the lesion, and post-insertion mammography film for confirmation. The patient is transferred afterwards to the OR. Another small video showing how do we place the localizing wire. Here we can see the clips after total vanishing of the mass lesion, previously proved to be Barrett 6 and pathologically showing complete radiological response. Here is the tip of the localizing needle. We advance it 1 centimeter below the localizing clips, and here how does it look when it's coming out of the skin of the breast. And we took post insertion mammography showing the clips and the wire over the clips, and we can see the conservative surgery, sparing the nipple, just the lumpectomy with a safety margin with the wire going on out of it. Another interesting case for stereotactic microcalcific wire localization. Right breast shows fine suspicious foci of microcalcification. The most serious thing was the ugly-looking axillary lymph nodes. Biopsy MRI was done and showed foci of non-mass-like enhancement. The patient was scheduled for wire localization under stereotactic guidance. Here we can see a closer look at the foci of microcalcifications. We can see it over here as well. The wire was placed within its center, coming out of the patient's breast, just excision with a safety margin. After surgical localization, the wire is tapped firmly and positioned to the patient, and the patient is advised not to to limit movement until transported to the OR. All surgical excisional procedures performed under GA. Advantages of breast lesion localization. Successful localization of the lesion using the plan technique to image and localize the lesion preoperatively. Successful excision of the lesion, less operating time, less length of hospital stay, less post-operative complications, recurrence, better cosmosis, and less post-operative pain. Another case showing dense breast ACRC. If we took a closer look, we'll see suspicious clusters of microcalcifications, and it was categorized by RADS4. MRI showed non-mast-like enhancement, taking a full upper-outer quadrant. MRI showed the kinematics showed type 2 curve and type 3 curve. So stereotactic biopsy was taken with the specimens showing the foci of microcalcifications, and it was imaged by mammography. Biopsy showed invasive duct carcinoma with focal DCIS comedo pattern and lymphovascular invasion. The patient had an insurance and she was offered to do PEM, and it shows uptake of the radioactive material in not was to do bracketing technique, where we, under mammography guidance, we place multiple wires along the boundaries of the microcalcification clusters. The patient had a large size breast that we can still conserve. Here how we do post images. The patient had a conservative surgery, and she was satisfied by not losing her breast. Thank you.
Thank you, Professor Ahmed, for this precise presentation. And now we have just 4 minutes for some questions. I looked for any questions. Just one question for you, Dr. Ahmed, about the feasibility of using charcoal in identifying the lesion in the neoadjuvant setting.
Actually, up till now, we didn't have the facility to use charcoal in identifying the axillary nodes. Instead, we do clipping, and during the operation, they used to see if the clipped lymph node is the sentinel lymph node or not. But up till now, we didn't use charcoal in identifying the axillary nodes.
Okay, I have a question for Professor Joly. You said at the end of your presentation that biopsy is mandatory in the metastatic setting. We have to take it once again. What about the discordance between the hormonal status in the beginning, in the primary, and in the metastatic setting? That's to say, if the patient was hormonal positive and changed to negative, will you avoid the hormonal treatment? And what about if it is the opposite?
So that's a very good question, and this does happen. So what I would say is, if it's a bone biopsy where decalcification was done, I'd be very cautious if the original primary tumor was strongly estrogen receptor positive, and now I'm being told it's negative, and I would want to really be careful and verify that before assuming that I shouldn't use endocrine therapy. But if it's, but with bone aspirates, which is what our preference is, it can be very accurate. And so I think, there can be heterogeneity. And if you biopsy one area, it might have somewhat different expression of ERP or HER2 than other areas. So taking all that into account, we do want to know what happened. And I do generally trust my very excellent interventional radiologists and pathologists to give me a result I trust. And I do base my treatment, even when there's discordance, on what's there now, what we've documented is present now, versus what was present in the breast, especially if I gave a lot of treatment, systemic therapy, that could have altered and actually pushed mutations forward as the tumor developed resistance. But we struggle with this all the time. It's a great question.
Thank you, Professor Joly. Thank you, Professor Gratier, for your comprehensive presentation. And really, it's very interesting because, as you said, that the number of countries are increasing in the use of the NCCN guidelines. And for Egypt, of course, it's the same. So it was very interesting to know how do you put it like this. And of course, taking in consideration the resources, it's very important. Thank you all.